Yep, that's good. That's good. So welcome everybody. For those of you who don't know me, I think most of you do. My name's Mervyn Morgan. I'm from the ITP Support Association. With us today, it's a pleasure to welcome Dr. Catherine Baggott, one of our medical advisors. Catherine is from the Glasgow Royal Infirmary, and she'll be here today to answer any of your questions you have. We're also joined by Mr. Derek Elston and Mr. Anthony Hurd, board members from the association, and also the association's senior patient mentor, and she hates it when I say that, Mrs. Rhonda Anderson. But so please, has anyone got any questions they would like to kick off with? There must be something about what's going on around the country with this Omicron variant.
No, that's banned. That's banned.
Our phone lines have been red hot the last few days. So, yeah.
I mean, I think that I don't know if anyone. Oh, sorry, someone had a question there. Sorry.
Tina, you got a question?
It was just, I feel really cheeky seeing as how I'm at least 100 miles further south than all of you probably.
You're a lot closer to the border than I am. So, yeah.
That's true. That's true. Do you know why people with ITP feel cold all the time? What causes it?
No, I don't know that. I know people with ITP have a lot of experience a lot of symptoms that are not just related to the bleeding, but we don't know the reason for most of them, to be absolutely honest. We think it's something to do with the immune system not quite reacting the way it should, but apart from that, I'm afraid I can't really give any more of an explanation than that, really. And there's probably not much you can do about it, but apart from layers. But yeah, I suspect, as I say, there's lots and lots of unusual symptoms that we know ITP patients experience. I think obviously fatigue is the most common one, and we do think that's due to some sort of inflammatory process that's going on as part of the ITP. So I think feeling cold is a less recognised symptom, but if that's what you notice, then and it's related to, say, your platelet count. So so some people will say, I know my platelet count's low because I feel really tired again, and the question is, do you feel that with the cold as well? And if you do, then it may well be related.
Do you think that it might be, Catherine, this is a question for you, do you think it might be an idea to ask your doctor if you can have thyroid function test?
Yeah.
Because, some of the thyroid problems are autoimmune as well, aren't they?
That's absolutely right. Yeah, and that's a very good comment. So if you have one autoimmune condition like ITP, you're much more likely to have others. And some of the thyroid conditions can be related to an autoimmune problem. So you can have low thyroid levels can make you feel cold. It's not definitely going to be the case, but that's certainly something that's be very sensible to do. It's something we generally test for anyway when someone's newly diagnosed with ITP.
Good question, Tina. Good question. Now,
Super, thank you.
On a similar vein about autoimmune and immune response, I know Rhonda had a question. Is it your vaccinator said something to you the other day?
Oh, yes. When I went to have my booster vaccination, I think it was, and they didn't say anything to me. You know how you've got to fill in on the form if you've had a splenectomy or whatever, if you have no spleen. So obviously I ticked that. And then I just reminded her, that that's what I'd ticked. And she said, oh, yes, she said, because you have no spleen, your reaction to the antibodies, you won't get as many antibodies as other people because you have no spleen when you have the vaccination. So I just wanted to know if you knew anything about that, Catherine.
Yeah, so someone who doesn't have a spleen is considered to have an immunosuppression to a certain extent. So, we haven't proved this, but yes, there are. This is why when you have your spleen removed, you're recommended to get your vaccines first. so that you can have the best immune response you can. So, you know, we haven't been able to prove this with COVID, for example, but there is always a concern if you don't have a spleen, then it's not so much just the antibodies, but it's the whole immune response. It's the response of the B cells, which are mainly responsible for making antibodies, but also the T cells as well, that are also an important part of the immune system. So, you know, we think so far that possibly immunosuppression, such as having your spleen taken out, being on steroids, may not be as bad as we thought. Having cancer does seem to be moderately bad in terms of COVID vaccine response. But, you know, we don't know for certain. But generally, you know, we are generally saying to our ITP patients who are on immunosuppression, who've had a splenectomy, your immune response may not be as good. And certainly before the vaccines, people who'd had their spleens out were told to, well, as you may know, this went backwards and forwards. To begin with, you were told you must shield, and then you were said you didn't have to shield, then you weren't. So it was very, very confusing. And I think that just shows that we're not absolutely certain. First of all, how much you're more prone to COVID and severe infection, and then how good your immune response is to the vaccine. But I always say to all my patients, some protection from a vaccine is better than no protection. So certainly recommend vaccine and the boosters to absolutely everyone, no matter how severe your ITP is. We've been very clear about that actually right from the outset.
Yeah, well, that's what I always tell people. Yeah, and when you're saying about cancer, do you mean they're people who are being treated for cancer, that their immune response would not be so good if they're actually being treated with chemo or something?
Yeah, so it may, depending on the type of cancer that you have, it may be even if you're not on chemo, your immune response may not be so good. So certainly with, say, blood cancers, because blood cancers are often heavily involved with your immune system, there's great concern that you won't mount a good response to the vaccine. If you're on chemotherapy, that's probably worse. But again, we still recommend the vaccine to those as well. I mean, there's loads of research coming out about this, and you know, it really varies from cancer to cancer, really varies. So yeah, and that's probably far worse. Well, almost certainly it's going to be far worse than being on immunosuppression. But, you know,
well, I know a guy, I don't know his health history, but he's obviously got some history behind him. And when he had the vaccinations before the booster, when he had the 2 vaccinations, he went to his clinicians and they tested him for antibodies. He actually didn't have any antibodies, even though he'd had the vaccinations.
Yeah, so that's what we can't be certain of, though, because it may be you don't have antibodies, but you still had an immune response in what's called your T cells.
Yes, he said that.
So we are doing a lot of work on antibodies. So, you know, I'm a healthcare worker, so I'm involved in something called the Siren study, which is looking for antibodies, but it's not everything with regards to the immune system. So certainly some vaccines we all have, you can't see antibodies if it's been more than 6 to 8 weeks since you had the vaccine, but you're still immune. So it's not the whole picture. But trying to test someone's immune response through their T cells is very hard sort of in a normal clinical laboratory.
Oh, thank you for all of that. Thank you.
I think
remember on the spleen issue last year, you know, as you quite rightly said, Catherine, there was quite a bit of confusion going on. And I believe, if my memory serves me correctly, Adrian Newland actually wrote to Dr. Nikki Kahani at NHS England about this very issue. And it took her about 2 or 3 months to actually respond on it, which was funny. And I also managed to blag my way onto a NHS England press conference, and I asked her the question, which is when they admitted that it, you know, the confusion was there, the wording was wrong. So yeah, it's a shame. It's a shame.
Very tricky.
Yeah. Okay. Any other questions, anyone?
Perhaps I could ask Catherine. We've heard a lot about T cells, and
yes.
That seems to be very much in the vogue at the moment, that they are going to be the elixir for quite a few different conditions. I'd be interested to know what you feel about T cells.
Oh, good Lord.
That's
a deep scientific question for 7 o'clock on a Tuesday. I have always thought that T cells are involved in ITP in response to, you know, with regard to this being an ITP forum. I think that we've known for ages that it's not just having, you know, antibodies against platelets that matters, but it's the whole T cell response as well, which is why some of the immunosuppressants we give to ITP are actually against T cells. So I think that's probably, I mean, I don't do research on T cells. I don't know loads about them. There are many different types, but I probably wouldn't want to say much more than that. But you have basically T cells that help your B cells to make antibodies, and you have T cells that are actually what we call cytotoxic in themselves, so actually can destroy cells themselves, which is why it's not just about antibodies when it comes to both, say, immune response to a vaccine or an autoimmune response. It can be dysregulation of B or T cells.
So we should watch this space and see what happens. Okay, thank you.
God, Catherine, you sounded just like Professor John Semple then, with all that explanation. Brilliant. Right,
Jenny's got a hand up.
Yeah, Jenny and then Betty. Jenny first.
Hi, how are you? I had 2 questions. So it's my son who's diagnosed with ITP. He's 5 years of age. He was diagnosed in March 2020. And the first one was just, he's now on platelet therapy drugs. So he's on Eltrombopag. And I was just wondering in this forum how successful you have found treatment on that drug, because he's kind of, I'd say it hasn't stabilized. He's on it since May of this year, and it hasn't seemed to stabilize. It climbs there recently, but it's dropped back down. So I was just wondering, has anyone had that treatment and how effective did they find it?
I suppose I should really let the patients in the group really respond to it first, but in terms of their actual experience. But if not, then I can explain what we know about Eltrombopag.
Has anyone had Eltrombopag?
Yeah.
Betty? You're muted, Betty.
Yes, I've been on it for years now, and it does vary. You know, they keep an eye on me, but it does work, and it's I haven't had any trouble with it, you know, really, that I know of.
You haven't had
things
any
happen to you, and you can't relate it. You know, you don't know if it is the drug or not, but basically, I've been quite good, yes, on Eltrombopag.
Thank you.
Jenny, you said you had 2 questions?
But did Tina want to say something about her experience?
Tina?
I was just going to say I was on Eltrombopag, but I couldn't stick with it. It gave me diarrhea.
Ah, okay, interesting.
So just from a medical point of view, so Eltrombopag is one of the few medications that's gone through really good randomized controlled trials, so comparing it to sort of standard treatment, and it performs really, really well. So, you know, about 85% of all patients do have some sort of response to it. Obviously, that means that 15% don't. So it's a really good drug to be on. Obviously, you've got the whole problems with the dietary restrictions, which for a 5-year-old must be a bit tricky.
Yeah, I try to do it in the evening so he can still have a cereal in the morning.
Yeah,
Yeah.
and often platelet counts can fluctuate on Eltrombopag, so it can be working, but then you'll have a blood test and suddenly the platelets will be down at 10 again. You think, oh, goodness me. But then if you just stick with it, they can come back up again. So fluctuations are quite common. You know, if the response is still not good, and he's been on it since May, you know, maybe it's not going to be the best one for him. But I think if it goes up and down, so there has been a response, but it does fluctuate, then perhaps it is doing a good job. But there are other medications. So Avatrombopag is now available, which, you know, can be used as a tablet as well if you wanted to.
In Scotland, yes. Yeah.
In Scotland, yes. Sorry, yes, in Scotland. So sorry, Jenny, are you not in Scotland?
No, I am. Yes, yeah,
Right,
I'm
okay.
based in Scotland. Yeah.
Yeah. So and you know, ramiprostim, although it's a little injection under the skin, is pretty well tolerated. So we know that if someone doesn't respond to one of these platelet stimulating drugs, they will often respond to another. So I sort of keep an open mind about it and just keep talking to the haematologist who's looking after your son.
Brilliant, thank you. The other question was, I've kind of through social network, I suppose, so online social network, it's great for building a community of people that have ITP and so on, because they're following hashtags. And I've made kind of social friends with someone who's based in the States. She's in her 30s, but she's actually trying manual lymphatic drainage massage at the moment in a way, like this is obviously off her own back that she's doing it, but it got me thinking, and I've kind of looked up who's qualified. So there's one person who's qualified here in Scotland in it, and I said, like, I explained it, they've never treated anyone with ITP before, but they could understand based on the condition itself and researching it and speaking to their kind of cohorts that it could be something that could aid symptoms, or it might help boost the immune system, so might have a positive impact. I'm just wondering what you kind of thought of that.
Well, I don't quite understand how that would help the immune system. I certainly haven't read anything about that in the journals with regard to ITP, I'm afraid. So I can't really comment. It doesn't quite make sense to me, but I if it doesn't do any harm and it makes someone feel better, but I'd be a little bit cynical about whether it could help improve a platelet count in ITP. I don't want to sound too medical, but that's my honest answer.
No, that's fine. I was wondering, because I mean, there's obviously something, and correct me if I'm wrong, because I'm still learning all about this, that the body is basically firing like falsely to say, oh, attack the cells. So I was wondering if kind of like stimulation of the immune system might kind of, I'm probably asking for a miracle here, reprogram. Do you know what I mean? Like, it's like, hey, we're after doing something, we're after massaging all it, knowing, you know, that can kind of release toxins and all that out of the system and potentially maybe help. I don't know.
Yeah, I mean, I think we know from all the research been done over the years that the ITP is definitely an immune problem. So there's definitely some problems with the immune system not firing, if you like, as it should. Partly B cells, partly T cells, releasing too many of these sort of what we call inflammatory proteins, which, you know, can cause some of these other abnormal symptoms such as fatigue as well. You see, I don't know anything about lymphatic drainage and how that could have an impact on your sort of immune system in terms of how it impacts on B cells and T cells and the spleen and other lymph nodes. It doesn't quite make sense to me from a scientific point of view.
Okay, thank you.
Thank you, Jenny. Thank you. Betty, you had a question?
Yes, I had both my vaccines, and then a few weeks afterwards I had headaches all the time. Well, I don't usually get headaches, and then they ceased, and I got swelling of my veins on my head. And then not long after that, I had double vision while I was driving, actually. So I went to hospital, and they said I had a clot, which I thought unusual when I've got ITP. The day before I went into hospital, not the day, the week before, I was 48. And when they tested me for my blood, they wanted to put me on aspirin. I said, I don't think I can take aspirin. And when they tested my platelets, they said they were 300 and odd.
Wow. So
I don't know how I went from 48 one week to 300 and odd the next. You know, and I'm a bit worried that it was the vaccine. So I'm scared to get the booster.
Oh, good Lord. So it was one thing I was going to sort of mention to the group actually, is that there's new guidelines out about ITP and the vaccines. I don't know if anyone's seen it. It was just released on the British Society of Haematology website last Thursday. So we haven't been worrying about the platelet count going too high in ITP patients with the vaccine, but we now know from data that's been collected that about 7% of patients with ITP will see a drop in their platelet count, a significant drop in their platelet count after any of the COVID vaccines. Doesn't seem to be, the type of ITP doesn't seem to be any different in terms of the way people respond to treatments. But what they are now recommending is, because people who do have a significant drop in their platelet count generally do it in the first week. So unlike what we were recommending a year ago, when it sort of said, you know, don't worry, you don't need to have your platelets count checked, just get the vaccine. Well, certainly the European Medical, what do you call it? The European Medicines Association, I think that's the EMA, I think that's what it's called. It's basically the equivalent of our MHRA, has said you can have a platelet count checked within a week of your vaccine, or basically between day 2 and day 5, because we're worried about going low. So I haven't heard about it going high. But my thought would be is that, may I ask, are you currently on any treatment
What for
for your
the
ITP?
I'm on Eltrombopag.
Right, right. So, I mean, platelet counts do fluctuate in Eltrombopag. I mean, the other thing I'd say is that whenever someone becomes unwell, it's very common for that. Well, it can do all sorts of things. I've seen people who are unwell with their ITP, their platelet count can suddenly go up, or it can suddenly go down. I think if it's more than 30 days since the vaccine, I doubt that the two are related. I don't know if we quite met that parameter, but that's generally our cutoff for blood clots or low platelets when it comes to the COVID vaccine. If it happens after 30 days, then it probably isn't related. But I suspect it's probably because you were generally unwell that your platelet count went up, would be my thought.
That much though, you know, it seems.
Yeah, no,
like-
it's amazing. It's amazing. Did it go back down to normal level afterwards?
Well, they put me on aspirin for about a week, but then my platelets started to go really low, so they had to.
Right. So I suspect that's just a marker of that acute event of the blood clot that caused them to shoot up. I don't think it caused the blood clot. I think you had the blood clot and it caused them to react and go up, because they're now going back down again. And I don't think that would be due to the vaccine. The vaccine has caused low platelets, and then it's caused this funny thrombotic syndrome, which generally only happens with the first dose of AstraZeneca, and that's almost always within 30 days. I hope that helps. I don't have all the answers, but that would be my thought.
Okay, thank you.
I've actually just put the link to that document you mentioned, Catherine, on the chat here. So
It's been there for a while, but it's just been updated.
it says it was published on the 9th, so
That's
yeah,
right.
about 5
That's right.
days. Yeah,
Yeah,
yeah.
but
Yeah.
so basically it's what we call a live document, so it's updated
that's
whenever we get new information. Yeah.
Okay, you've got 2 hands up, Derek and Rhonda. Derek, then Rhonda.
Catherine, are there very many patients that have been on Eltrombopag where their platelet count has risen and continued to rise even after they've been taken off the drug? I only ask because when I had bypass 6-7 years ago, I was taken off the drug the morning after I'd had the op, and of course my count dropped back to 10. But since then, it last check a couple of weeks ago, 220, and it's gradually risen for no, as far as I can see, apparent reason.
Yeah, I think, again, I would say I think there's so much we don't know about ITP. So the vast majority of people, if they haven't gone into remission after a couple of years, generally don't go into remission. But we now know that there are still some that will go into remission spontaneously after 5, 6, 7 years. The other thing we now don't know is whether Eltrombopag and Roriplostim are actually somehow modifying the course of ITP. And so for all my patients who are on eltrombopag and roriplostim, if they have a normal platelet count on either of those drugs, then every year I will stop the drug and see if they've gone into a spontaneous remission. So, and then the other thing I'd say is that when you have a big event, bypass, for example, who knows what happens to your immune system? So your body goes through this massive shock, this massive trauma, and that could easily, I think, do something to your immune system. Just as it might cause ITP, it might actually cause it to go into remission. So when you tell me that, I don't have a scientific explanation, say, well, that's because they did this, that, or the other. I think it's just that your body took a big hit and the response was to normalize your platelet count and put the ITP into remission. But I don't have a scientific explanation for that, I'm afraid.
Interesting. I'd like to just pass comment to Baldy about the aspirin. After I had the operation, they wanted to put me on warfarin, and I said, oh, no way do you want to put me on warfarin. I'll be bleeding out fairly quickly. So I've had no anti-clotting therapy until a couple of years ago when I was talking at a meeting in Madrid, and Jim Bussell from the States was there. He was horrified that I was taking at least a dissoluble aspirin per day. And he said, you need to get that sorted because you are in danger zone. So I now take an aspirin a day, but that's just a frightener that you put on me.
I think when you've got ITP and you've had bleeding problems for many years, and then someone says take aspirin, you're like, hang on a minute, that's going to be my platelets don't work. That's mad. But it's always a balance of risks and benefits. So we know, first of all, that platelets in ITP patients are very good platelets. So because, you know, your bone marrow is working well, you're making young platelets all the time, but they're being destroyed too quickly. So what is there is good. And aspirin is actually quite a weak antiplatelet agent. So I'm completely happy using aspirin when the platelet count's above 50. I wouldn't give it a second thought. And depending on the risk-benefit balance, I would even go down to 30. Just to give you an example, is that patients who undergo things like epidurals or have what they call spinal anesthetics when you numb them for the waist down, they now do that commonly for hip replacements. Anaesthetists will do that procedure even if someone's on aspirin. So their platelets aren't working very well at all, but they'll still do that procedure because and what I'm trying to say is that it's an example of, even though it's such a delicate procedure and you're doing it right by the spinal cord, which if you get bleeding can be very, very serious. We're all very relaxed about aspirin now. So yes, it does have a negative impact on platelets, and it is brilliant at preventing further strokes and further heart attacks, but it doesn't seem to be associated with a significant increased risk of bleeding. So, you know, in someone who's had a recent stroke or a recent heart attack, unless their platelets were less than 30, I would be quite happy for them to be on it. It's very different when you get into other antiplatelet agents such as clopidogrel, which is much stronger. I wouldn't want to use that in someone who had ITP, particularly if their platelets went up and down. And then you'll often hear this expression these days of dual antiplatelet therapy. And again, I would not recommend that in someone with ITP. But aspirin, as doctors, we're all very relaxed about. So hope that
Thank you very much.
Thank you, Derek. Rhonda?
Yes, I'm sorry, this is backtracking a bit on the discussion, but I once had a bad virus, like a flu virus, and I thought that my platelet count would go right down. But in actual fact, when I went to the hematology department, I saw the consultant. I never used to see the consultant. And I walked in and he said, I was going to discharge you today, but I can't discharge you because you've got a platelet count of 850. And I thought he was going to say, you've got a platelet count of 0 or something like that. And I said to him, well, that's funny. I thought it'd be right down. They put me on aspirin. And I came back in 4 weeks' time or something, and it all normalized again.
Mm.
But that, I say that to illustrate that when you have, as Catherine said, you know, an event, a sort of catastrophic event for your body, for your system, it doesn't always mean that the platelet count is going to go down. It can
Yeah.
also go up.
I think that's particularly true of a infection, because your immune system is triggered, you know, so just as it inappropriately gets triggered against your platelets, it appropriately gets triggered to kill the flu or kill a bacteria. And so that could easily have an effect on your incorrect autoimmune response.
Yeah.
So you're absolutely right. If one of my ITP patients has a viral infection, I'm like, oh goodness gracious me, they're going to bleed. But not always. Sometimes platelet count will go up. It'll generally
Yeah.
come down again though, but it'll
Yeah, yeah.
go up.
And I do have another point of about the previous discussion as well. I do actually have ITEC qualifications in massage. I did it many years ago. I haven't kept it up. I'm not up to date now. But lymphatic drainage was one of the things that was on the agenda. And I never trained for it or did it because I didn't see how that could help at all. And when I used to treat people, and I didn't treat many people because I didn't go into it very much, but friends and so on, I used to always say to them when they came for aromatherapy massage, you know, there's no promise that this will do anything. If you feel relaxed and you feel that you get some benefit from having a massage or from having any kind of treatment that you might go and have, like a facial or a foot massage or reflexology or whatever it is, then, you know, that is the benefit to you, that you have had some relaxation, that it's been good for you. We can never say that relaxation is bad for you, and that you will get something out of it that way. But there was never any promise that it would do anything for you. And I think that's what you have to remember with all of these complementary alternative therapies, is that to some extent, you know, you have it done because you're going to feel better for having it done, but it's not actually going to be a medical intervention which is going to do something to your body to cure it or even heal it. But, you know, your spirit might be healed a little bit, your emotions. If you're feeling very stressed about having ITP or stressed about your lifestyle, then something like that can help you to relax and help you to feel better. And it can also release endorphins in that way, you know, the feel-good hormone. But you know, we talk about the sort of sensible lifestyle. And if you look, you know, every now and then the Daily Mail comes out with, oh, we've discovered the most wonderful thing about, you know, curing everything. And it's always, you know, eat well, sleep well, relax, exercise, you know, have a sensible diet, don't be overweight, don't smoke, you know, don't drink. And it's just common sense.
Keeping fit is very boring. You know, it's like the things that are good for you, I'm afraid, are boring.
Yeah, yeah. So the thing is, really, basically what I'm saying is have a sensible lifestyle, and you've done pretty much all you can do, apart from medical interventions that the medical profession will advise you on.
Thank you, Rhonda. I see Bonnie's joined us. Bonnie, have you got a question?
Hi, so sorry I'm late. No, I'm
It's
just
okay.
enjoying listening to kind of what's going on. I had my booster, and I know last time that I spoke, I was worried about not having a good enough platelet count for the booster. But we talked about maybe increasing my eltrombopag to 100, and I did that for 4 days, and it did exactly the trick. It was a bit much because it gave me massive headaches. But I did it for a really short term, and it bumped my platelets up to a place where then I took the booster and just felt more comfortable with it. And I know that's sort of my own pseudoscience around, I don't want to be below 20 when I take the boosters or any vaccines. But yeah, so I did a really short burst of an increased amount, and it kind of did the trick, and now I'm back to my normal dose. So that was really helpful from last time. So this group has been great for me just to bounce ideas around. So, but yeah, thank you, Mervyn, for asking.
Thank you, Bonnie. Did you have any reaction to the booster, Bonnie?
No, so because before, when I took my jab number 1 and 2, they didn't want to do my platelet count. But this time the hospital was really clear. They wanted to see me within 7 to 10 days after my Pfizer. And I was really surprised because I was trying to do that the first time round and the second time round. And they were like, no, don't worry about it. We're not that we're not interested, but we're not. And this time it was absolutely, you must come in 7 to 10 days after. And I guess that's just because there's been more data about platelets and they're trying to, so I was no problem at all going in to give a bit of data, but my platelets hadn't dropped at all. So it was a bit hard to tell because obviously I'd had 4 days of sort of an increase in Eltrombopag, but they were higher than before. So I seem to not react to Pfizer, a bit like Rhonda was saying. I think actually I tend to go up when I've had some drama in my body. So when I had my iron infusion, I shot through, well, when I say shot through a roof, I went to like 90 and I'm usually about 30. And I think it's when I've got a foreign body in my body, so to speak, it gets all confused and forgets about killing my platelets. And then for a little while, I have high platelets. So I have wondered whether licking the pavement every day, just getting a low level infection would really help my platelets. My consultants did look at me quizzically when I suggested that. It was a bit tongue in cheek, but I do think there's an element with me that if there's something bigger going on, my platelets seem to survive longer. I don't know if anyone else has found that.
One of the theories about why we now have so much autoimmune disease is because we don't have as much worm infestation as we used to, because we're not licking the floors. I mean, I use that as an analogy.
Yeah,
generally not being as clean. So I'll often, joke with friends who have become new parents, like, don't worry, don't feel you've got to like sterilize everything. Let them, get a bit dirty and they won't have asthma when they're older. Now, we don't know that for certain, but there is some thought that our society and the fact we're so clean and hygienic now may have led to more autoimmune conditions. Just to say in response to Bonnie, because obviously you weren't here at the beginning. So when the COVID vaccines first started to happen, and we knew there could be a link of them making ITP worse, because we know it does it with other vaccines, but we didn't have any data. So and because we knew that millions and millions of people getting vaccines, we just didn't know exactly what to expect. So it's only in the last, well, I don't know when the paper came out, but basically we now have about 3 journal papers that have demonstrated that platelet count goes down in about 7% of ITP patients who have a COVID vaccine, and it generally happens within 2 to 5 days. So we've just updated the guidance on the British Society of Haematology website, and Mervyn has posted in the chat that link. So I mean, I have to say, I've always felt that it's bleeding that matters the most, to be absolutely honest. Although I completely agree with the guidance, I'm completely happy with that, and I'll be checking the platelet count on my patients, but it's the bleeding that matters. So if you're not bleeding, then actually I wouldn't alter your treatment. So even if your platelet count, if I find it has gone down at day 5 from 30 to 12, if you're not bleeding, I wouldn't alter anything, because it'll come up again. So yeah, but Bonnie, that's probably why it changed. That they were saying, oh, you must come back and have your platelet count checked, is because we've got this new data.
Yeah, that makes sense. And I love a bit of data, so I was well up for it. So you can have as much blood or tissue as you like.
Well, I think the other thing they're very interested to try and work out. So we've now got data that's with quite a lot of patients, that it's about 7% of ITP patients, their platelet count drops in the first week. What we're now trying to work out is if it did drop with the first or the second, is it going to drop with the second or the booster? We just don't have enough data yet. So our ITP forum chair, Quentin Hill, has put out another alert to us all saying, please, please, please let us know, you know, if you get any more data on any of your patients, so that we can work out if it's gone down once, is it going to go down again? So we've currently got data on something like 30 patients, and 4 of them dropped their platelet count second time round, you know, after so they dropped it with the first, and it dropped again with the second. And that comes out at 27%, but I think that we need a few more patients, rather more than 33, 4 out of 33, before we can sort of say what the risk is again of it going down.
Just on
So-
that, we've got a survey out, COVID survey, which I just sent the latest download to Dr. Sue Pabbard and Dr. Jim Purcell last week. We've got about 335 patients have actually completed it so far. First dose, second dose, and now booster doses.
Excellent.
They're
Okay.
doing.
Yeah.
And,
It'll come. Yeah.
Yeah. And so, Bonnie, if you haven't filled it in yet, the link's on our website. Please fill it in, especially with the details about your booster dose, because I know Dr. Sue Pabbard is using that. She's used it already in one abstract they've done, one paper they've done, and Jim Purcell has done the same. So, you know, hopefully we will get far more people completing that as well. I think it's actually, believe it or not, on par with a similar survey that the PDSA in the States started just after we started ours, and we've got probably as many of they, you know, returns that they have. So I'm really pleased with it. So yeah.
Yeah, and the doctors are being asked to do the same thing, is to
Yeah,
put in data. Yeah.
Sue Pabbard keeps phoning me up and asking me, have you got any more? Have you got any more? So yeah, she's using them. Okay. Rhonda, your hand's still up. Have you got another question?
Yes, another point. Following on from what Catherine and Bonnie have said about, you know, the immune system being triggered or whatever. I can't quote what the study was, but quite some time ago, because my daughter has asthma and so on, so interested in all that kind of thing. They did a study of these children who lived in places where the animals lived in the house with the children. And so they, like some places in Switzerland, they had the animals underneath and you know, the family above, cows and sheep and whatever they had. And in other places too. And they found that the children had a lot less asthma, hay fever, eczema, all of those different things. And they said it was because they were exposed to all of those things, you know, like the dander on the animals and the hay and the whatever it was. And so I just thought that that was an interesting point, that, you know, you were saying, Catherine, that we're too clean, and Bonnie, you were saying about, you know, being exposed to the normal stuff. But it's very hard, isn't it, to balance it? Because, I mean, when you've got little children, you know, you don't want them to fall ill with sickness and diarrhea, you know, because, you know, we know that in some countries that is actually a killer. Yeah. And it can be very bad here. But they do actually vaccinate now for rotavirus, don't they?
Oh, do they?
Yeah, because when my grandson had the rotavirus, my son said to me, you mustn't change his nappy, because they've said anybody who is immune suppressed is, you know, prone to it. So I had to keep away from all that sort of area when he had the vaccine for it.
I mean, it's really, really contagious, rotavirus. Really, really contagious. Yeah. I was just going to say though about, let's not all start living with animals, because that's led to coronavirus. So
yeah, exactly.
Let's not do that.
And I have to say, you know, that I am not fond of animals. I don't have pets because I'm allergic to them.
My cat is listening in now. He decided to come off my lap.
Oh, hello, Pussy. I love you at a distance.
Okay, Bonnie, you got a question?
It was a quick one, really. From the last meeting, some people were talking about avatrombopag who had been able to take it, and if you read a lot about kind of people's dealings with avatrombopag, people are raving about it. And I know that we were talking last time that it was supposed to be going for licensing in January. It might be being put off by 6 months. I don't know if there's an update or whether they're still delaying it or they're doing it early. But I mentioned it to my consultant. So I've been on all of the different things, like the myriad, like probably everyone has. And I'm sort of stuck on eltrombopag, which it sort of works, sort of doesn't. I hate the dietary things, and my liver's a bit crazy with it. And so all the avatrombopag ticks all the boxes for me, and the fact that people have said, you know, it's really made a difference. I mentioned it to my consultant because I know that we were talking about you can have it as a named kind of person to access it potentially. And basically, I was told that my hospital won't be using it. Like quite clearly, they won't be using that because the ones they use, they're happy with. And I was like, oh, and I must say, I didn't expect that. I expected to be told we just can't get it for you. But it was more like it's unlikely we'll be using it even when it's licensed. So does that mean I'd have to change to a hospital? If I wanted that, does that mean I'd have to change to a hospital who were using it? How does that work?
Are you in Scotland or England?
No, I'm England.
Oh, okay. So it's not been approved by NICE yet. So
It's been delayed until we've been told early spring, but everyone has put a complaint into NICE to try and get it brought forward. So we'll see. Yeah.
So it as you rightly say, Bonnie, it's now it's in England, because this is what I had to do when I used avatrombopag in Scotland before it got approved. You have to do a special application for a named patient. Yeah, it's a bit difficult for me to comment. You know, I think you know, if you are having liver inflammation with eltrombopag and eltrombopag works for you otherwise, then avatrombopag is a potential goer. But
yeah, I mean, I've only had one crazy moment with my ALT going to like 360, but basically I came off every supplement, everything. I was taking supplements and different things as well, and we lowered my eltrombopag dose, and it all settled after about 3 months. So I'm slightly kind of, and I've got Gilbert's syndrome, so my bilirubin is through the roof all the time anyway. So and my dad's had liver failure, so there's a liver issue going on in the background. So I was just wondering whether it would be kind of a sort of gentler drug, but it was like, if they aren't going to do it, do I have to move hospitals to hospitals that are doing it, or can you request a hospital that's not using it as one of their go-to drugs to prescribe it, or they won't really want to because it's not what they want to do?
I think what I would do is I would just keep asking your consultant haematologist.
Okay, and to see, and wait for it to be licensed, I guess.
I mean, when it's you say it's England's always a bit, even though I'm obviously English, England's always been a bit confusing to me, because it now all seems to be based on CCGs, and which seems to lead to postcode prescribing, which I think is not right, because I thought that's what NICE was supposed to all be about. So if it gets NICE approved, then it used to be, when I lived there 11 years ago, that the hospital had to prescribe it if it was appropriate. And Mervyn, you remember better than me, but it seems that's not the case anymore.
There are quite a few instances around the country of postcode lottery, basically. Yeah, for various things. But hopefully, you know, we need to see what the NICE decision is, you know, the wording of their decision, like, you know, whether that will put any emphasis on it, because we don't know what price has been agreed either as yet.
I would be amazed if NICE don't approve it. I would be really, really surprised.
I from the report we did, Adrian and I did, and we've had the support of some of the people on the call tonight. We are quietly confident that it will get through. You know, we're just annoyed that NICE has said, due to committee pressures, they've delayed it, which is crazy. Yeah.
And in your experience, have you found that that's the response from avatrombopag is quite good?
I haven't used enough patients yet. So because it only got approved in Scotland on a non-named, so, you know, just generally. Probably 2 months ago, because I know
Yeah,
I know
it
when I
wasn't
had
long, was it? Yeah.
it wasn't
yeah.
long, because I know the last patient I prescribed it for, I haven't prescribed it for anyone not on a named patient basis yet. So basically, if I've got patients who are completely, right now, if I've got patients who are completely fine, Eltrombopag or Romiplostim, then I stick with that. But if it were to happen, it hasn't happened yet, I have a patient who isn't coping well with the dietary, so I'll ask patients, how you getting on with the diet? And if they go, oh my God, it's absolutely awful, I'll say, well, we could try Avatrombopag. Or if the liver function goes off, I'll be saying, we really ought to be trying Avatrombopag. I mean, in terms of the research data, the research is there to say that it's effective. Now, Eltrombopag and Avatrombopag have not been compared head to head, but it seems to be giving similar results. Obviously, we don't have as long-term data with Avatrombopag, so there's stuff that isn't known, but on the face of it, it seems to give a good response, as Eltrombopag and Romiplostim we knew did, say, 8 years ago. So as I say, I think just you sound like a lady who can probably, speak for herself. So just keep asking your consultant, what about Avatrombopag?
Yeah, I was reading a bit about how they were saying, how that idea where you move from Romi to Eltrombopag and back, and sometimes which direction you do it has an effect on that. So some people say that if you move from one to the other, then going back is quite difficult. But I haven't found that. I did Eltrombopag, lost response, went to Romi, lost response, and went back to Eltrombopag and had a response. And they're saying about Avatrombopag that if you go from Eltrombopag to Avatrombopag and then back to Eltrombopag, it might not be as effective. But like you say, is there enough data to even suggest that?
No, not at all. I mean, I would, if someone didn't respond to Eltrombopag, so forget the LFTs and the dietary issues. If someone didn't respond to Eltrombopag, I would go to Romiplostim next, because Avatrombopag works in pretty much the same way as Eltrombopag, whereas Romiplostim doesn't. In terms of moving from one to the other, we definitely know that if you go from Eltrombopag to Romi or Romi to Eltrombopag, you can get responses on one and not on the other. But I've never gone back to an old drug. So someone didn't respond to Eltrombopag, I put them on Romi, they didn't respond to that. I haven't gone back to Eltrombopag. Having said that, you get to a point for, unfortunately, some patients where you'll try anything.
Yeah, that's what we did.
Yeah.
I think basically I lost response to Romi just before COVID and all the trials shut down. So I was about to go on a trial. All the trials shut down. And I also didn't really want to be going into hospital every day doing trials when there was COVID. So we then did that. Well, let's just try Eltrombopag again. And bonkers, it worked. Worked to some extent. I mean, it was working to like 30 to 40 thousand, and that's kind of enough to keep me going. So
I know
thank you.
It's very unfortunate that the trials all had to stop.
Yeah.
Okay.
Thank you,
Bonnie. Thank you. Right. Any other questions as we move along? We're getting near the time. Tina? You muted, Tina.
Sorry, I'm clicking the wrong bit. Just a really quick one. Is there anything new on cerebral microbleeds, please?
Oh, so I have to confess, I have not recently looked at the literature, so I'm not aware. If Mervyn, if you want to give me a little email reminder afterwards, I'm more than happy to look up about that data and bring it back to the next meeting.
Will do.
So
I'll get it to you, Tina. Okay.
I don't know, but I will look.
Thank you.
Right. Any other questions? No. Rhonda?
Just trying to unmute. Oh, I'm still muted, am I?
No, you're not. No.
Oh, okay, it came up that I was. I just wanted to ask Catherine about her views on Omicron and what's going to happen, what you think might develop or not develop, or do you have any views? Or I know it's early days and I know that there's lots of unknowns, but do you just want to give, just in the last few minutes, do you want to give a little rundown on that?
Yeah, well, most of us live in Scotland, so you've probably all heard Nicola Sturgeon's speech, whatever statement that she made today. I think it's definitely more contagious. So I think there's some really important things to know the term. So it's definitely more contagious, and transmissible. So that is absolutely clear. You have some immunity, it appears, with 2 doses of the vaccine, but nowhere near as good as you did against Delta. So that's why boosters are so important, and that's why they're saying to everyone, please, please, please get boosted. So anyone who hasn't been vaccinated or hasn't been boosted, please, I can't recommend it strongly enough. Even if you've got a platelet count of 0, I still recommend the COVID vaccine. But what we definitely do not know yet is that whether it's more virulent, so whether it causes worse disease, the same level of disease, or milder disease. I really don't think we know that yet. And I think anyone who sort of says, oh, well, it's just going to be milder, they don't know that. They don't know that. So I have to say, whatever anyone's political persuasions are, I think the advice that Nicola Sturgeon gave today was absolutely spot on. Is if you go out and have contact with anyone, please do a lateral flow test before you go out. Limit your contacts as much as you can, particularly, I mean, I know this from family members I'm hoping to go and visit in England for Christmas Day, is that one of those is very immunocompromised with cancer. And so I plan to have no social contacts between now and Christmas Day, because the last thing I want to do is take it with me. And it's actually making me slightly anxious, if I'm honest. So so I think if you want to make Christmas Day as good as possible, that Christmas period, is to really limit your social contacts, because although if we're all boosted, we're highly unlikely to get serious disease, it's a matter of keeping those safe who don't have a good immune system, and also who may not have been vaccinated for whatever reason they've decided not to get vaccinated for. So I'm no expert, but that's my take on what's been said.
Can I just say something? Over the weekend, I asked Professor Newland to just do a quick article for us, for the website on Omicron, but also on COVID. And an interesting take on this, Adrian has said, from the London hospitals that he deals with, currently over 90% of those who require admission to ICUs are unvaccinated.
Absolutely,
And
absolutely.
nearly half of those who require ventilator support are dying, with an increasing number of under 40s being affected. This is putting an enormous burden on the NHS, and it is totally preventable. So
yeah, whether it's totally preventable, I don't know if it's totally preventable, but I think that it's absolutely correct. Exactly the same in Scotland. Almost everyone on ITU is unvaccinated. That's why they keep stressing, please, please, please get vaccinated. And now, unfortunately, because Omicron, please, please, please get boosted. But I think that because we don't know how virulent, so how serious Omicron might be, we need to reduce transmission as much as we can. So anyway, I'm going to shut up because I don't want to sound like a politician.
One thing I was just going to ask
okay,
about
final
was,
question to Anthony. Yeah,
I was just going to throw a very quick comment on that in terms of how long do we think any effectiveness of the booster vaccine will last. So at what point and how far into the future might we need to have a booster, or whatever? And I guess maybe we don't know the answer to that yet.
Yeah. We absolutely don't know.
No.
We absolutely don't know.
So in other words, just be prepared for this to go on for some
I think
while.
I tell myself that you can't look very far in the future at the moment. You just have to, this is how it is. This is what we need to do that's sensible, and just take
in theory, if the virus continues to mutate, and what appears to be happening with this particular strain is that it is more transmissible, perhaps, we don't know yet, but it might weaken, and gradually the whole thing will just weaken as it gets more desperate to spread itself quickly. But of course, we can never really say with any certainty any of that, I guess.
We don't know.
It's all disappointing, but we just have to.
Yeah, it's pretty grim, really. But never mind.
Yeah,
Happy
we need
Christmas,
to end
everyone.
on a high note.
Yeah,
It's
happy
Christmas.
Christmas. Yeah.
Right.
Where's the sherry?
Anyway.
Yeah.
Before we go, just very quickly, just a few things looking to the future. Hopefully, we are still planning to have our convention as an in-person event on the 14th of May. We're still planning. I've agreed with Adrian that we will give it until at least mid to the end of January before we decide yay or nay. But at the moment, we're still planning for an in-person event, which will be followed a couple of weeks later by a sort of mini hybrid event as well, you know, with recordings from the in-person plus a live Q&A. But that's on the 14th of May. Once I get the go ahead, I put all the ticket details up on the website. But finally, I'd just like to thank all of you really for, I know this year's been awful. Last year was awful as well, but yeah, it's, you know, got worse and worse as we come along.
Oh no, Mervyn, this is
But
Trying to end on a high note, Mervyn.
I am. But even though I've had to cancel my Christmas in Disneyland Paris with my granddaughter,
Oh,
we're still going to have a family Christmas at home. So I just hope all of you have a lovely Christmas. Thank you for all your support during the year. And Tina, I love the new haircut. That's the hairdresser coming out at me from many years ago. So lovely to see you all. Thank you very much, Sue. Thank you, Anthony, Derek, and Rhonda. And most of all, thank you, Catherine.
no
Have a
problem
lovely
at all.
Christmas.
Happy
All the
Christmas,
best,
everyone.
everyone.
Bye bye.